So cholesterol, let's start with that. The myths, the facts,
Mm.
and the fear. There's a lot of confusion about this topic, Ross. What is it? How much does it actually matter?
Yep.
How can we lower it? Let's cover them all. Let's start with exactly what is cholesterol.
Well, cholesterol is just a waxy, fatty-like substance that's a vital component of everything that goes on in our body. So if we took all the cholesterol out of our body, we'd be dead within a few hours. We must have cholesterol. But why are we so obsessed with it? Well, it's actually historical. Well over 60 years ago, a lunatic biochemist from America called Ansel Keys came out with a theory that fat and cholesterol caused heart disease.
Mm-hmm.
And at the same time, a guy called John Yudkin from the UK said, no, it's not cholesterol and fat, it's sugar. And the sugar industry shut him down, and they let Ansel Keys become the voice of all this. And so Ansel Keys published, now wait for this one, I've never been able to figure this out. He published a thing called the 7-country study, where he released the information from 6 countries after having analysed 22 countries, but he didn't like the information he got from 16 out of the 22 countries, so he just released the 7-country studies on 6 countries. I know it sounds very confusing, but this was the nonsense that was back there in the 60s. And people then came out with this cholesterol hypothesis. And we've swallowed this nonsense, figuratively speaking, for the last 60 years or so, 60, 70 years. And it's really quite bizarre that people still believe that cholesterol causes heart disease. And here's the issue. You've heard, Shelley, of course, of the good and bad cholesterol.
Mm-hmm.
LDL bad, HDL good. That is simplistic nonsense. LDL, and now I'm going to give you the real reason for all this. LDL and HDL are divided into small bits and large bits. And here's where size is important. The larger your LDL, the larger your HDL, the healthier it is for you. So I want to now absolutely dismiss all of these myths about cholesterol. Myth number 1, there is no link between total cholesterol and heart disease. Never has been, never will be.
Wow.
So just because someone's cholesterol's high doesn't mean they're going to have heart disease. Just because their cholesterol's low doesn't mean they're not going to have heart disease. It doesn't work like that. Now, again, LDL, another myth. LDL is not bad, HDL is not good. It's the size. So the thing that actually causes heart disease is oxidized small LDL cholesterol. Large LDL cholesterol is very important for cell function, cell communication, cell membrane structure, vitamin D metabolism, bile salt metabolism, steroid metabolism, all of these things that are so important for the way the body normally functions. So we need large LDL.
Mm-hmm.
Small HDL is pro-inflammatory. Large HDL sucks fat out of your arteries. So we want the large LDL, we want the large HDL.
Mm-hmm.
I'll give you a great example. A 50-year-old woman goes into a doctor with a cholesterol of 7, considered very high, but an HDL of 2.5 and a triglyceride level of 0.7. And the doctor goes, oh, your cholesterol's high, you're going to die from heart disease, you must be on a statin. Complete scaremongering nonsense. That person is what we call typically a lean hyperresponder, and they've just got a lot of large LDL, large HDL. It's very good for them. But
Right.
There's a very simple way to sort it out. In 1999, I introduced into Australia, in conjunction with the Sydney Adventist Hospital at Wahroonga, a thing called coronary calcium scoring. Coronary calcium scoring is a CT scan, takes a snapshot of your arteries, no dye, no injections. It's very low radiation. And I believe all males at 50, all females at 60, as a routine, should have a coronary calcium score. But if you're a 50-year-old woman who your GP wants to start you on a statin,
Mm-hmm.
you have the coronary calcium score then. And with that profile I just mentioned, high total cholesterol, very high HDL, low triglyceride, so that's large LDL, large HDL, their coronary calcium score is almost always 0. And I don't care if your cholesterol is 10, if your calcium score is 0, you do not need a statin. Now, you said right at the start, and this is the key point here. Every year around the world, there's around 17 to 18 million deaths from heart disease. At the start of the pandemic, I was on Channel 7 and I said, look, if people are so worried about their health and security, stop stockpiling toilet paper, stockpile fruit and vegetables and exercise equipment, because one person dies in this country alone, in Australia alone, from heart disease every 12 to 20 minutes. So that's the killer. Now, why is it still causing carnage despite this excessive prescription of statin drugs? I can tell you why. It's very straightforward. Statins are a small part of anyone's management. And here is the key to this entire issue. Whether you are 20 years old, whether you're 95 years old, 80% of your management is what I call the 5 keys of being healthy. It has nothing to do with damn doctors. We're not that powerful. But what I'm about to tell you, Shelley, is powerful. You practice these 5 keys, you reduce your risk for cardiovascular disease about 83%. You take a statin to lower your cholesterol in an average dose, you reduce your risk about 20 to 30% with a potential for a bucket of side effects. So what are the 5 keys? From the least important to the most important. Number 1, you cannot be healthy and smoke, drink too much grog, or snort cocaine. Number 2, 7 to 8 hours of good quality sleep is as good for your body as not smoking. Number 3 is nutrition. And there's so much nonsense said about nutrition, but I want to give you the key message about nutrition. It's not just what we shouldn't be eating, but it's what we should be eating. Only 5% of the population have 2 or 3 pieces of fruit per day, 3 to 5 servings of vegetables per day. Servings about a half a carrot, not a huge amount, but only 5% of people who do that. And those who do have the lowest rates of heart disease and cancer and Alzheimer's disease in the community, and it doesn't do zip to your cholesterol. What it does is keep your immune system healthy, damps down chronic inflammation, which after genetics is the key to all of these problems. So fruit and vegetables, all of us should be doing that every day. We should be avoiding anything in a box or a container masquerading as food, because it isn't. It is just, it's excessive calories without any good nutrition. So it's very simple. If it's in a box or a container, and I don't care what graffiti is written on the box, like no cholesterol or low fat, all that sort of crap. If it's in a box or a container with a use-by date, it is bad for your health. End of story. And unfortunately, that's where most people get their I won't use the word nutrition, I'll say they'll get their calorie satisfaction from, and it's nonsense. And also what I call white death. Any form of sugar, white bread, pasta, potato, rice. I'm not saying don't eat these things. I'm saying minimize your intake of all of these things. That's number 3, nutrition. Eat less calories, eat more natural food. That's all you need to know. Number 4 is the second best drug on the planet. 3 to 5 hours every week of moderate exertion. And tragically, Shelley, only 25% of people do that. And then finally, easily the best drug on the planet is a thing called happiness. And there's a little known university in America called Harvard, one of the great learning institutions in the world. And they have been doing for 85 years a thing called the Grant Study. The one key to health and happiness is to have someone else in your life who loves and cares for you, who you love and care for. It's much more important than your damn cholesterol level. And that's what really does my head in. I'm a professional speaker. I go around the world talking about all this stuff. And one of the things I say in my talks is so many people are climbing the ladder to success on the wrong wall. And all this nonsense about focusing on a number in your bloodstream, which is exactly what you said at the introduction. We're focusing on one number in your bloodstream is the key to good health. You think about how stupid that is.
Yeah.
The key to good health is lowering a number in your bloodstream with a pill. I mean, really?
Yeah.
It's just nonsense. The blue zones, the 5 areas around the world where they haven't heard of damn Lipitor or Crestor or gyms. They just live a completely normal, natural life, and they move all day and they eat fruits and vegetables. They don't smoke. They have a strong sense of community, and they're the longest livers on the planet. Now, getting back to what you said about the young man who had to give the eulogy at his father's funeral, age 47, who died suddenly. Let me make another really important point here. All disease is genetic. Now, that doesn't mean, see, people get the Reader's Digest genetic stuff in their head and think, oh, my dad didn't have it, therefore I'm not going to have it. That's what genetics is about. No, it's got nothing to do with genetics. Every human being, unless they have an identical twin, there's no one on the planet has the same genes as them. I've got families where there are 5 siblings, 3 have vicious disease, 2 have nothing. And why? Because every gene is a coin toss. We're made up of about 20 to 25,000 genes, and each gene is either, well, you get one from mum, one from dad. That's genetics 101. So every gene is paired. So you can either have 2 good ones, a good and a bad one, or 2 dodgy genes. So if, for example, in cardiovascular disease, we've already mapped around 300 genes for cardiovascular disease and function out of the 20,000 genes in the body. And if you've been born with 200 out of 300 dodgy genes, either good, bad, or bad, bad, you'll probably get heart disease in your 40s, 50s, and 60s. If you've been born with only 50 out of 300 dodgy genes, you probably won't get heart disease at all, or maybe get it when you're 85. That's genetics. And so what I say all the time, it's your genes that loads the gun, then it's your environment that pulls the trigger. And with heart disease, 70% of heart disease is related to a very common gene, probably the commonest gene abnormality in the world, called the gene for insulin resistance. So 30% of Caucasians, 50% of Asians, and close to 100% of people with darker or olive skin are born with this gene for insulin resistance. And as soon as you expose someone with this gene to Western crap, that's when they start to get problems. So tendency to diabetes, blood pressure issues, high triglyceride, low HDL, which is a marker for small LDL, small HDL, and it's easy to get fat around the belly. That's why you've never seen a skinny Tongan, because they're the world champions of insulin resistance. They have the highest rates of obesity and diabetes in the world because of their severe insulin resistance gene. So it is definitely genetic, but their environment has pulled the trigger. If you expose them to a good natural hunter-gatherer sort of existence, they wouldn't be overweight. And so the true pandemic of the 21st century is not COVID, it is diabetes, which sets you up for all of the problems of insulin resistance, which are cardiovascular disease, obviously obesity, obesity-related cancers, fatty liver, gout, and in women, polycystic ovaries. So that's a bit of an overview of cholesterol for you, why we're so obsessed with it, but it's so wrong, because you know what? It's a beautiful solution, to quote the Donald. It's beautiful. I don't like quoting the Donald, but anyhow. But it's a beautiful solution, because the fat guy goes into the doctor and says, oh, doctor, I've got cholesterol. The doctor doesn't say, no, you're a fat slob, you've got to lose weight. The doctor says, oh, I can fix that. Here's some Lipitor, here's some Crestor. And the guy walks out and goes, oh, phew, that was
I'm
great.
saved.
I didn't get a lecture about being fat. I can eat what I like and take this pill. And that is biologic nonsense, because the cholesterol component of your health is one small component.
Imagine this, unlocking your genetic blueprint with insights from over 200 healthy aging genes, pinpointing your unique SNPs and potential red flags, understanding what your body needs to thrive and where it may need some extra support. No more guesswork, no more random supplements, one-off blood tests, or one-size-fits-all advice. For the first time in history, we have access to the power of genetic testing, something no generation before us has had. This information could change everything. Join our free DNA webinar and you'll get our Stay Well scorecard jam-packed with the markers that we want you to track every year, starting now. Friends, know your genes, own your health. Let's learn to thrive together. Visit theagingproject.com to register, and I'll see you there. The 5 keys, and we have spoken about that. As you said, it starts with having no vices, drugs, alcohol, cigarettes, of course, sleep. We know that how important that is on our list. Exercise, nutrition, happiness.
Yep.
they're all our responsibility. That all
Yep.
comes down to the individual working it out themselves. Obviously, it is much easier if someone in a place of authority, like a doctor, says, here's a box, here's some statins, that's going to fix everything. As you said,
Yep.
it completely takes the pressure off the human and puts it onto the system. So are statins valuable in any situation? Where do they work?
Oh, they're absolutely valuable as 10% of your management. See, I talk about the 80-10-10 rule. 80% is lifestyle, 10% is the appropriate use of pharmaceutical drugs when you need them. I'll tell you when you do. And the other 10% is the appropriate use of evidence-based supplements, which most of my colleagues don't even believe in.
Mhm.
And there's a whole host of supplements I use in my patients appropriately based on their own needs. But let's get back to your question. When do statins work? Statins should only be prescribed in two situations. One, if you've already had a clinical issue related to atherosclerosis. Now, what do I mean by that? You've already had a heart attack, stent, bypass, or an atherosclerotic related stroke. You should be on a statin. I put people on statins all day in those circumstances. The only other people who should be taking statins are people who've had a coronary calcium score that places them well above the average risk for their age. So I'll give you an example. The average coronary calcium score for a male over the age of 70 is about 200. So if
Right.
I've got a 70-year-old
How
male,
high does it go, Ross? Are we
oh
talking
look, look,
0 to
zero to
400?
whatever.
Zero
No,
to
no.
whatever.
So zero is what you want.
Mm-hmm.
And so for example, 50% of 50-year-old males have a 0 score, but if you're a pessimist, 50% don't. But when you get to age 70 as a male, I'll go to the female statistics in a second. 70 as a male, about 50% of men have scores below 200.
Mm-hmm.
So if I've got a man comes into me with a high cholesterol and he's 70 years old and he scores 100, I wouldn't go near a statin with him. There's no way. There's no way. But let me tell you what the scoring ranking is. 0 is what you want. 0 to 10 probably has about the same prognosis. 10 to 100 is mild atherosclerosis. So the calcium score is just a marker for how much atherosclerosis you have, which is, imagine a donut like that. The fat builds up in the wall like this,
Mm-hmm.
and the calcium grows in to act as a scaffold to stop the fat from breaking down. So the problem is fat, not calcium. But the calcium is very easily measured, and it's a good marker for fat.
Gotcha.
So 1 to 10 is mild. 10 to 100 is mild. 100 to 400 is moderate, and above 400 is don't read Tolstoy. Just stick to green bananas and don't eat green bananas and stick to small pamphlets. No, but if you do nothing about it. But the worst calcium score I have, this is a great story, is a 68-year-old man in the fitness industry, doesn't have an ounce of body fat, normal cholesterol, blood pressure, never smoked, not diabetic, no family history. So he has none of the standard risk factors for heart disease.
Which is what we would normally go in and be
Exactly.
tested for. Yeah.
Exactly. But what he does have is an elevated lipoprotein little a. So that's lipoprotein, lowercase a in brackets.
Mm-hmm.
Now, doctors have been measuring this thing that causes 20% of heart disease. Doctors have been measuring it for the last 2 or 3 years because, you're going to be shocked by this, we're now developing drugs to lower lipoprotein little a. So there are 5 drugs being researched around the world to lower lipoprotein little a. I've been measuring lipoprotein little a in my patients for 30 years, and I've been treating it with a vitamin program. Now, let me tell you an anecdote, Shelley. This is not a clinical trial, it's an anecdote. I'll tell you this anecdote after I finish the story about this other guy. This man's coronary calcium score, the 68-year-old man with no risk factors but the high lipoprotein little a, was 8,100. His arteries were like porcelain pipes. 10 years ago, he had coronary artery bypass surgery under my supervision. A few years back, he sent me an email with a picture of him and his mates winning their latest basketball grand final, and he'll live till he's 100 now, having had very successful bypass surgery and being on my preventative programs that'll make sure he never has a problem. Now, let me go back to the anecdote. 30 years ago, I saw a man, age 40, whose father had bypassed in his 60s, grandfather died in his 60s of heart disease. So I measured his lipoprotein little a, and it was very high. So I started him back then on a combination of vitamin C, vitamin E, and lysine that I've been using successfully in many patients for the last 30 years. And this man came back to see me at age 70 about a year ago. I sent him for another coronary calcium score, and it came back at nothing. Now, that's an anecdote, but I'm saying these things can be managed. And again, I will use the medications when they come out if they've been proven to lower cardiovascular risk.
Mhm.
But the supplements also work along with exquisite lifestyle, because here's the big problem. Homo sapiens as a species are a sorry lot. You line up 100 people, you put them onto any program, after 12 months, 50% have stopped.
Mhm.
And of the other 50 left, 40 out of 50 have modified the program to what suits them. So it's only 10 who are still following your advice. So the people like this guy who didn't miss a day of his vitamin C, vitamin E and lysine, and 15 years ago, I started him on a bergamot product, which comes from the bergamot orange in Calabria.
Mhm.
And he stayed on all these things devotedly for the last 30 years. And that's why he's 70 with a 0 coronary calcium score.
So this is what we should be looking at instead of our cholesterol numbers. And again, if you can just run me through when we do have those tests, obviously it has a scale as well. And you said
Yep.
that seven is high. When we first hear those numbers from any GP, we're going to be shocked or amazed either way. What is a good number? What is a bad number? Just so we can then
The
process
good
that
number.
ourselves.
The good number is very straightforward, Shelley. It's a 0 coronary calcium score.
Mm-hmm.
So again, another anecdote. I saw a woman in age 58 came to see me. Her lifelong cholesterol was 9.5, because we'll have to get onto the unusual condition called familial hypercholesterolemia soon. But 9.5 cholesterol is considered extremely high. So every scaremongering doctor said to her, if you don't take Lipitor, you're going to die. And so she tried the Lipitor for 3 days, and she just could not lift her arms from severe muscle pain. And about 10% of people cannot tolerate statins. So she heard about me, came to see me, age 58. I sent her downstairs for a coronary calcium score. It came back 0. So I said, look, in your case, your cholesterol and all of its mates are not spilling into your arteries to cause fatty plaque. Keep your lifestyle tight, take some supplements, which I prescribed. Come back and see me in 5 years, we'll do another study. Anyhow, she didn't come back for 8 years. But for the next 8 years, every scaremongering doctor said, if you don't take Lipitor, you're going to die.
Mm-hmm.
And she listened to me, not to them. So she's now back here at age 66, sent her downstairs for another coronary calcium score, and it had rocketed from 0 up to 0. And it was still 0. And I mean, seriously, in her case, she doesn't need a statin. But I've got a 32-year-old woman whose father died at 31. Her lifelong cholesterol is around 12. And I measured her coronary calcium score only because of her father's death. I wouldn't normally do coronary calcium scores on 30-year-olds, because you want to avoid radiation up to about 50 if you can.
Mm-hmm.
And so anyhow, her coronary calcium score came back at 48, which is in the middle of the mild range for a 50-year-old, but it's a huge amount for a 32-year-old.
Mm-hmm.
So I'm hammering her cholesterol with a statin, because she probably will die like her father did
Mm-hmm.
from her unusual condition, familial hypercholesterolemia.
Mm-hmm.
Still genetic, but this particular abnormality drives up your cholesterol to very high levels. And in that situation, I already gave you one example of familial hypercholesterolemia where it did nothing to the arteries, whereas another one where it did something to the arteries. That's why the coronary calcium score is so important, because it tells you who's at risk, who isn't at risk.
Mm-hmm. And you wouldn't know that unless you had a coronary calcium score. You should not be taking statins until you have had a coronary calcium score.
Absolutely. Absolutely. Let me tell you another story. And these are just anecdotes. This is not clinical trials, but this is 45 years of clinical experience.
Mm-hmm.
I saw a man at 38 who came to see me, and some ill-informed fool had put him on a statin when he was 28 because his cholesterol was high and his uncle had a heart attack at 55. That was the justification. This fellow went on to tell me...
Which is common. This is very common.
Yeah, very, very common. But this fellow wanted to tell me how his wife had been through 10 unsuccessful cycles of IVF until it twigged in his head that maybe it's the statin I'm taking that's stopping me allowing my wife to get pregnant. So he stops the statin by himself without the doctors saying it was right. And she gets pregnant naturally within 6 months. Now, Shelley, that's medical negligence.
Mm.
That's $100,000 worth of IVF. But forget about the
Well,
money, the
psychological
misery,
pain
the
and
psychological misery of going through. And also, a lot of people don't realise this. If you have failed IVF, it doubles your risk for heart disease over the next 10 years because it screws up your hormones. So I just think people have to understand what we're doing. The medical profession should live by the Hippocratic Oath that says, first, do no harm.
mm,
So once we start throwing heavy drugs at people, that's when we've got to say, okay, these drugs can have a good effect for some people, but they can also cause problems for others. So
mm.
that's how I do it. I really focus on the 80% lifestyle. Pharmaceutical drugs, if there's a strong medical indication to give them, not just, oh, your cholesterol's high, take this pill. And that's just almost a mantra for
Mm.
most doctors. And I just don't get it because you'll say to me, well, why do they do this? You're not doing it, but why are they doing it? I can tell you why. There's normal, there's your severe heart disease. All the evidence that shows statins work are in these people up here. They're extrapolating that evidence to people down here.
Mhm.
It just doesn't make any sense.
So is this what you'd call pharma washing, I guess? And is it GPs that are prescribing this? Because obviously it's big money and it is driven by Big Pharma, and there
Uh,
is an enormous amount of
yeah,
money being spent on that here in Australia,
yeah, but
$20.4 billion.
I
But is it
get
also that GPs, I mean, they don't know?
no. I don't think the GPs know. I gave a lecture, basically with what I've told you today. I gave a lecture to about 500 GPs a few years back in Sydney. They just all sat there with their mouths open and go,
Mhm.
what's this all about? This is not what we're led to believe. You see, they've just been. Look, I don't think it's farmer washing. I think it's easier. To do what I do with people, you actually have to sit and talk to them. Whereas
And
to
then
write
they've
a
got to do the
script,
work,
yeah, and
don't they?
then the responsibility goes back to them. Oh, but
Mhm.
doctor, just give me a pill. And
Yeah.
I'll tell you a funny story. About 15 years ago, I was on the Catalyst program talking about transcendental meditation. I've been meditating every day to this morning for the last 35 years. And I couldn't imagine a life without meditation. So a guy called Tim Carr, who's a mate of mine who also practices TM as well, we both went on Catalyst talking about the health benefits of transcendental meditation. So what they do in Catalyst, reasonably so, they always have to have the antagonist to give the opposite argument. And this guy is a general practitioner. He came, I won't say his name, but he went on the show and he said, why would you waste a half an hour a day meditating when you can swallow a blood pressure pill in 5 seconds? I mean, seriously? Yeah.
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 And he's out there as an educator as well.
Yep. And I rest my case on that one.
So let's say, I mean, statins are the most prescribed drug globally,
Yep.
but we also know that prescription drugs are now the third leading cause of death behind heart disease and cancer.
Look, I would say, no, the commonest cause of death is heart disease, cancer number two, Western healthcare number three, not just
Mhm,
prescription drugs. It's Western healthcare in general. It's
mhm.
it's inappropriate procedures. It's procedures that should have been done but have gone wrong. And it's also pharmaceutical therapy. 10% of admissions to hospital are due to medical error.
Mhm.
And so I just think all of us in the medical profession have to think very, very carefully what we're giving our patients, what we're telling our patients, what tests we're doing on our patients, and giving appropriate advice around that.
Gut health is a topic that many of our guests, like Dr. Frank Lipman and Catherine Maslin, have mentioned in the past, which is why we have a range of products we've researched over at youmusttryit.com. We encourage you to be proactive about your gut health and let us help you resolve any ongoing issues. You can also book a health coaching appointment over at youmusttryit.com. Just go to health coaching to learn more.
Most of the time, we are far too focused on the treatment and not the prevention. And I
Yep.
guess that starts today and how we go about our lifestyle and our movement and our food for a better future to live to we're 100. You mentioned earlier, and we didn't really dive into this FH or
Yep.
familial
Hypercholesterol.
hypercholesterolemia.
That's it. Yep.
What is that and how many people carry it?
Look, it's not that common, but it's so focused on by the medical profession. 1 in 250 people
Hmm.
have the gene for FH, and there are three different abnormalities that do it. There's a thing called ApoB, there's the LDL receptor, and a thing called PCSK9. So you can have a mutation in one of those three genes that sets you up to having cholesterol somewhere sitting between 7 to 10, maybe a bit higher for some people, but it's average 7 to 10. And these people can be as thin as a rake. And again, another misconception. Cholesterol doesn't have much to do with what you eat. Cholesterol is genetically primed, related to your metabolism. When a woman hits menopause or a man hits andropause about age 50, around 50, the cholesterol almost always goes up because your metabolism's changing, because your hormones are changing. So it's really got nothing to do with diet, with your diet. And so people who'll have very high cholesterols will go into a rigid diet. Their cholesterols will drop for a few months, but it'll go back to where they were because your body thinks that's where your cholesterol should be. So people with FH, their bodies think their cholesterol should be sitting between 7 and 10. And this is the really interesting thing about FH. About 50% of people with FH, with those very high cholesterols, normal HDL, normal triglycerides, will have a vascular event by age 50, but 50% won't. That's where the calcium score comes in. And that's how I use the calcium score. So yes, it is a very significant condition. And yes, they often need to have statins to lower their cholesterol if they've got atherosclerosis. But we now have this madness where some doctors are even suggesting children should start statins.
Oh, God.
Now,
What about why wouldn't you do genetic screening rather as a part of standard care rather than this?
No, but even then, even if you did the genetic screening and picked up they had FH, you start an 8-year-old on a statin?
Well, no, you start them on a great lifestyle program, do you not?
I think every child should be on a great lifestyle program, but I'm saying there's no way I would be giving a child a statin unless for some reason they'd already had a heart attack at age 10, and that's as rare as rocking horse manure. It just hardly ever happens. And there's a thing called homozygote familial hypercholesterolemia, where these children are born with 2 genes for this FH, 2 genes, and their cholesterols are 10, 11, 12, 13, 15, 20 from birth almost. And so
they would know that, as their parents would both carry this. But if you don't know that your family has this gene, say you had the 2 combined, mother and father gave it to you, but they've both lived good lives, healthy lives, no vices, getting lots of sleep, very much in love. It may never show up. So as you say, your genes load the gun, environment pulls the trigger.
Yep.
Their child has this double bout of it.
Yep.
Wouldn't genetic testing be a great thing to have a part of standard care?
Absolutely. But again, this is for health authorities, not for an individual doctor to make this decision. But you've got to say that condition, familial hypercholesterolemia homozygote, is about 1 in a million, not 1 in 250. It's about 1 in a million people who have that condition. So to screen 1 million people to pick up the one is just not cost effective. So I think you've still got to look at, in that situation, you do have to look at family history. And if there's a family history of rampant disease, like I've got a number of patients whose father died in their 20s from heart disease. Now, they're typically the people with FH, whereas lipoprotein(a), that's more people who get heart disease in their 40s and 50s. So it's just a matter of, and that's what I always do. I look at the common genes, insulin resistance gene, lipoprotein(a), something we haven't even mentioned, but I'll throw it in, the MTHFR gene, which occurs in about 50% of people as well. I've got the worst mutation for that. So I've got to take a 4th generation folic acid to keep my homocysteine levels low, because that's another component of heart disease. So there are all these different components that people like me deal with all the time. And it's all because I've got this bizarre notion, Shelley, you're going to find this quite bizarre, but I think it's better to prevent a heart attack than actually treat it.
Bizarre. Very bizarre, Dr. Ross. Why would a doctor not want any patients?
Yeah.
It is an odd concept, but I love the fact that we are able to have this excuse me. I love the fact that we are able to have this conversation with someone as knowledgeable as you, because I obviously am not part of the medical profession, but I do believe to have both sides and for people out there to have a conversation with someone like you, whether it be third hand through a podcast, just begs them to ask the question of their own medications, of the advice that they've been receiving, and to just, I guess, as I said, question that a little bit more. Not to say that all of our listeners that are taking statins shouldn't be. That is not the case at
No,
all.
no,
But to
not at all.
ask a deeper question to your GP and to question, again, that knowledge that we all think we have about cholesterol because we've heard so much about it over the years. Just ask more questions of your
Yeah.
doctors.
Well, look, I think doctors should be two things to people. I think they should be educators and servants. That's it. No doctor should ever talk down to a patient. No doctor should ever tell someone what to do. When people come to see me, I say, look, I'm not saying I'm right. I'm just giving you my opinion. That's all it is. And I've seen two world experts on a particular subject fighting tooth and nail that their position was right. And the other one said, no, mine's right. It's bizarre and arrogant to say that. I'm just saying, I'm looking at the science, and the science is telling me very clearly. I'll give you an example. 13,500 people between the ages of about 50 up to 75, followed for 10 years. Those who had a zero calcium score, zero benefit from being on a statin. Those whose calcium score was between 1 to 100, no statistically significant benefit from being on a statin. So there's a thing called the number needed to treat. And the number in this particular study, you had to treat, if your score was between 1 to 100, you had to treat 100 people for 5 years to prevent one heart attack with no difference in death rate. So would you put on a strong synthetic metabolic regulator to 99 people for 5 years to prevent one out of 100 having a heart attack? I certainly wouldn't do that. I just think that's absolutely outrageous to do it. And I've got to tell you, the worst call to my radio show, just a shameless plug, I have a national radio show every Sunday night on the 9 radio network, 7 to 9, it's called Healthy Living. But that aside, the worst call I've ever had to my radio show was a woman who rang up and said, my 95-year-old father's general practitioner wanted to start him on a statin because his cholesterol was 5.2. Now, you're not allowed to use the term effing idiot on radio, so I didn't. But what idiot would measure cholesterols in an asymptomatic 95-year-old? That's the first point. Secondly, why would you even talk about drug therapy for a 95-year-old? Thirdly, 5.2 in a 95-year-old? I mean, really? It beggars belief that anyone would even consider that sort of approach.
So if we were to start today, say we call it the Dr. Ross Walker 30-day heart health plan.
Yep.
If you could speak to our audience, who are mainly sort of 35 to 80-year-old females, about what they could and should be doing to ensure that they are doing the best possible or taking the best possible care of themselves that they can.
Yep.
What's better than measuring just your cholesterol?
Well, the first thing is to find out where you are. So if you're saying 30 to 50-year-old females should not be rushing off and having coronary calcium scores unless someone in your family has had heart disease very early. So I've got a 38-year-old woman whose father died at 45, whose mother had bypass in her 60s. She's 38. Her coronary calcium score was already 290, off the scale for a 38-year-old. I'm hammering her with a statin. So for the average person from 30 to 50, if there's no rampant family history, it's still a good thing to know where you are with things like what are your cholesterols doing, what's your blood sugar doing, what's your blood pressure doing, have a lipoprotein little a measured just once. You only need it done once. It's either high or it's low. So have an assessment first.
And are they things you can have through your GP? Can you get a CCS at your GP, or where do you go for a coronary calcium score?
Absolutely. So if you're 55 and the GP's starting to talk to you about cholesterol, by all means say, hang on. Before you even talk about cholesterol, I want a coronary calcium score. Now, I've got to bring this up because this is, the coronary calcium score is done on a CT scan. So it's about 10 chest x-rays of radiation. You just hold your breath for 10 seconds. They take a snap of your arteries, measures how much muck you've got. And these things here that sit in the chest like that all day, pulsating away, keeping me in a job. And so, but the GP will say, oh, no, that's a very expensive test. They inject you with dye. Because that's the thing called a CTCA, a CT coronary angiogram. That's not the same thing as a coronary calcium score. CT coronary angiogram, they put an IV line in, they inject you with dye, you glow in the dark for 3 days afterwards because there's a lot of radiation in most machines. most CT machines. Some CT machines is generally very low radiation. That's only
Right.
in a few institutions. But also it makes your wallet $500 lighter, and you potentially could damage your kidneys from the intravenous injection or have an anaphylactic reaction to the dye, whereas the coronary calcium score is just a snapshot. So if anyone's listening, they go to the GP and go, oh no, that's a very expensive test, that, and they inject you. No, I'm not talking about that,
No.
doctor. I'm talking about a coronary calcium score. No injections, no dye, and it cost me $150 to $200.
Great.
So,
So anyone
after,
over 55 should be
yeah.
having that
Oh,
as
yeah,
a
well,
baseline marker.
males at 50, females at 60 as a routine, just like a woman would have a mammogram or a pap smear or whatever. But also the bloods. And that, so firstly, assessment. Secondly, please, everyone, my main message, lifestyle is king. How you look after yourself is 4 times more powerful than anything a damn doctor can suggest. So don't come into me with a bucket of supplements, but a big fat gut or a fag hanging out of your mouth. The supplements will do nothing. They will not, they're called supplements. Supplements to what? To a healthy lifestyle. So lifestyle. So that's 80%. 10%, if you want the day, you say 30 days, 10% medications only if you need them, and the supplements. So the supplements I put everyone on, and this is not a 30-day program, this is a lifelong program. I at the age of 50, I give everyone the Bergamot products. I can't mention the actual name on because this is a public podcast.
We can look them up at drrosswalker.com, correct?
No, BJE 100 is the ingredient. So if you put that into Google, you'll get it. But also that, and a few of the other things that I use, there's a thing called kyolic garlic. So 2 capsules of those keeps your blood pressure low. A mate of mine called Matt Budoff, who's a preventive cardiologist in the US, did a trial where he gave people 4 of these a day with proven vascular disease, reversed their vascular disease with kyolic garlic. So I put most of my, and I'm taking all this stuff myself as well. So kyolic garlic. Now I take ubiquinol, which is the active version of coenzyme Q10, and a magnesium orotate aspartate combination. And again, I'm not giving the product name, I'm just giving the ingredients because that gives me energy. Now, every single person who's on a statin, I give them those 2 because the statins attack CoQ10 in the mitochondria. That's why you get the muscle aches and pains with statins. And the ubiquinol magnesium orotate aspartate combination helps minimize potential risk from the muscle problems from the statins. But I just take it to give me energy. And then
So
finally,
this is for anyone, whether they're already on statins, whether they just want a better quality of life. These are the supplements. And again, supplements not being medication, they are supplements for things that we possibly used to get in our diets that are from nature, that now that we're a bit older, our bodies either aren't absorbing it as well or we're not getting it in the food we're eating.
Yeah, well, even then, the reason I think people should supplement in our modern world is physiologically, evolutionary-wise, we were designed to last for 30, 40 years, wandering around a jungle in a completely natural environment, and then die from trauma or infection. We're living now double our use by day, which is about 40, because no one at 40 is as good as they did when they were 20. No one at 60 when they were 40. 30 is the peak of your life, and it all starts to go down. Osteoporosis starts at 30. Loss of muscle mass starts at 30. Hand-eye coordination is not as good over the age of 30 as it was when you're up to. That's why all the best high-performance athletes, apart from Roger Federer, were at their best up to the age of 30. So the reason we need to supplement is not just because we're not getting it in our diet. If you eat the diet I've said, of course you're going to get high quality nutrients, but because we're exposed to more synthetic chemicals, more chronic stresses, more background radiation, I think we just need that extra bit of protection. And we live in double A years by day. We need that extra bit of protection from the supplements. The final one I want to mention is vitamin K2, 180 mics a day, takes the calcium out of your arteries, puts it back in your bones. So it makes your arteries more flexible and makes your bones stronger. So I do all of those things. I take a bucket of supplements every day. And things like a high quality multivitamin, a high quality omega-3, and one thing we haven't even mentioned, which is vital, vitamin D. Because the problem is that most 30% of the population are vitamin D deficient because we've all embraced the slip, slop, slap message, as we should, because Australia is the skin cancer capital of the world. But the studies are showing now that taking 2,000 international units daily of vitamin D is very beneficial. One study showed a 25% reduction in autoimmune disease, but there's a link between low vitamin D susceptibility to infections. We saw that during COVID, and low vitamin D is linked to osteoporosis, heart disease, cancer, multiple sclerosis, type 2 diabetes, depression, asthma. Need I say any more?
To hear an integrative cardiologist, a preventative cardiologist, tell us to get outside, eat good food, exercise, sleep, hug, they are the keys to looking after yourself.
Yeah, and look, absolutely the keys. And two major trials, one called the Morgan study, another one called the Million Veteran study, showed that if you do all those things well, and tragically, Shelley, only 10% of the population do, you reduce your risk for cardiovascular disease 83%, as opposed to 20 to 30% from a drug that has a potential for side effects. I just don't know why the message is not getting out there. It's just easy because it's easier for people to swallow a damn pill and just abuse their body in whichever way they like, up to the moment of their heart attack or their bowel cancer operation.
And then they still find it difficult to stick to that. And I know it is hard. It is hard work, but it depends what sort of life you want to live, how you want to live when you're older. And we spoke to the wonderful Dr. Stacey Sims not long ago. She said she wants to be having Zimmer frame races when she's 100. And I agree that most of us listening really want to do that. To be able to speak to you today, Dr. Ross, and have it spelt out so clearly. And as mentioned, we're not anti-medication in any way. We are pro-information.
And
it's great to chat to you. Thank you. You've given us so much to think about.
Pleasure.
Thanks, Dr. Ross. We're going to put up all your details there, where people can get hold of you, where they can listen to your shows, your podcasts, and get the information direct from our doctor's mouth. Really great to have you with us again. Thanks.
Thanks, Shelley. Lovely to be with you.
As always, the Aging Project podcast is for educational and entertainment purposes. Always seek medical advice from a qualified practitioner.